here's a case, cervical case, 48-year-old female. She presented with a 3-year history of loss of upper extremity dexterity, progressive gait unsteadiness, neurological examination. She had left deltoid weakness, 3 out of 5, hand intrinsic weakness and unsteady gait. You can see on the MRI up there on the right upper side that she had T2 signal changes, severe spinal stenosis. She underwent a C5 to C7 ACTF with HA peak cages. And the reason I'm showing this here is it's just remarkable. If you look down there at the 3 months follow-up X-ray, you can see the cage here nicely integrated. None of that, halo around. And interestingly, if you look very carefully, you can see a nice bridging bony area here in the posterior aspect. And I had a case 3 months, 3 levels today that was basically a spitting image of this I saw earlier today in clinic. So this is a very routine finding now at the 3 months X-ray that you basically see basically a solid fusion at this time point quite commonly. Another case that has a year follow-up here, a 51-year-old female. So she similar presentation, upper extremity, loss of upper extremity dexterity, progressive gait unsteadiness. She also had left intrinsic muscle weakness, positive Babinski's unsteady gait. And she underwent a C5 to C7 2-level ACDF of a plate, and you can see down here the follow-up. Her neck pain has decreased to 2.5. She scratched out the 3, give it 2.5. Shoulder pain 3 from before 9 and 7. Arm pain is gone. So a really nice follow-up, and again, very similar to the 3 months. You can see this nicely bridging bone in the posterior aspect right behind the graft. So really not even a question if she fused. So it's very, very solid arthrodesis. And one lumbar case, I do a lot of standalone A-lifts with this. 58-year-old female, had a 1-year history of left lower extremity radicular pain in an L5 distribution. She was neurologically intact on examination. You can see on the AP X-ray here up in the middle that she was collapsed on the left side with vertical foraminal stenosis. You can see that here on the sagittal T1 weighted image on the left upper extremity, as a left upper side on this up here. Measuring out the vertical foraminal height, this was less than a centimeter, and that's when I typically recommend a structural reconstruction of that level. So in my practice, if your foraminal stenosis without unilateral collapse more than a centimeter, typically do an endoscopic foraminal decompression. If, as in this case, there's unilateral collapse due to coronal deformity, like in this case, with less than a centimeter, then endoscopic decompression is, in my mind, just a lot of time for typically a very limited and temporarily limited good outcome. So we did a structural decompression and reconstruction of that level with an ALIF standalone. And you can see a CT scan 1 year after the procedure, solid bone growth and a solid arthrodesis in this patient. So excellent outcome, and again, a nice fusion. I think, Sig, you have a couple cases here.
Yes, thanks, Christoph. And I'll share a couple of cases here as well with sharing some of my experience. I've been using the HAP composite interbody graft primarily in the lumbar spine and for the vast majority of my lumbar interbody fusion. So here's just a couple cases I thought were demonstrative of how well this is working in my hands. The first one's pretty straightforward. This is a 46-year-old male. He had surgery previously with a dynamic stabilization system. So from L3 actually to S1, he had a fixed and progressive sagittal plane deformity after a laminectomy with a dynamic stabilization. So this is what his x-rays look like. And you can see with the distraction dynamic stabilization device that was placed from L3 to S1, he had lost certainly significant lordosis from L3 to S1. And as we actually, if you just stay on that standing film for a minute there, Christoph, you can see he's got a bit of a thoracolumbar kyphosis above this. wide laminectomy from 3 to 1. And again, he was dynamically stabilized in a malalignment, so you really recognize the extent of his sagittal plane deformity. His occiput is really pretty well localized over his femoral heads, but having said that, his pelvic tilt is over 50 degrees here, so significant sagittal plane deformity. You see next slide, if you look this up, you can see that his CT scan demonstrates really there wasn't even an attempt to fuse this. This was an attempt at a dynamic stabilization. So what I did, because there wasn't a fusion in the back, I went ahead and did an antibody fusion. I went from L3 to S1 and really gained some significant, actually in this case it was L2 to S1 with the HAP composite antibody grafts. And perhaps it's more impressive to show on the lateral view, I got significant lordosis back from that 2 to 1 segment, 3 to 1 segment with these grafts. And then this was a same day two-stage surgery, but I didn't go back, front, back. I just went in the front because the dynamic devices in the back were mobile. I was able to gain lordosis, and then in the back, I instrumented up across the thoracolumbar kyphosis with a very nice restoration of his sagittal parameters and replacing his lumbar lordosis in the appropriate place from really L4 or L3 to S1. And this was just an example of using those ALIF grafts to sort of overpower posterior instrumentation, although in this instance, the posterior instrumentation was relatively flexible. The next case I'll show might be a little more dramatic with regard to what can be done with the antibody graft. This is a 59-year-old woman. She had progressive low back pain, numbness, tingling, radicular pain in the L5 distribution, and she'd undergone more than 5 years of non-operative care with facet injections and transfemoral injections. And finally, she came to surgery when she felt that her right leg, her dorsiflexors were actually getting weak. So she had a significant decrease in her ability to stand or walk, and travel is a big part of her life. She wasn't able to travel. If you look at her films here, you'll recognize that she's got a dysplastic spondylolisthesis. So this is really a grade 4 olisthesis of L5 on S1. And you can see here on the close-up view a little more clearly what's happening here. She's got doming of her sacrum and some changes to the L5 vertebra. And on the CT scan, you can see a relatively rigid grade 4 olisthesis. Now, this is a case where this patient has a significant lumbar pelvic mismatch. Overall, her global alignment is well preserved, but she's got a lumbar pelvic mismatch. And my goal in this case was to really restore lordosis from the L5 to the S1 and trying to decompress the L5 foramen. And this is a case that I commonly do with a posterior approach and a PLIF. Commonly, I'll do a sacral dome osteotomy and gain a reduction of the olisthesis. In this instance, her anatomy was such that I thought it was reasonable to do this from an anterior approach. And so I'll show you a couple of shots from within the operating room of how I use the Innovasis HAP case to gain a reduction. So this is a shot in the operating room where I've got an anterior approach. I put a malleable retractor up underneath the sacrum, underneath the top of S1, and I used my osteotome, took off a bit of a lip of the bottom of L5, and got into that L5 S1 interspace. Go ahead to the next slide, and then I actually put my HAP cage and I drilled 2 screws up into L5. So what I did is I took my cage and I fixed it to L5. And I kept my insertion tool on the cage. So with my insertion tool on the cage and 2 screws up into L5, that really gave me a terrific capacity to manipulate the L5 vertebra. And you'll recognize how we're starting to open the foramen here quite dramatically. That foramen was really quite collapsed earlier. But now I'm pushing the cage and the L5 vertebra back onto S1, so actively reducing that olisthesis, and go on into the next slide there. And then once I've got the L5 position where I want it to onto S1, I went ahead and put in my inferior screw, locking that reduction of the oleocesis, so the reduction of the forward slippage of L5 onto S1. And that was a really, I think, a case that demonstrated the capacity of me to use this cage and actually to manipulate a vertebra and create a active reduction of a high-grade oleocesis. And then I went on ahead and finished the cage. Because it was a high-grade oleocesis, I actually put an anterior plate and then posterior fixation with fixation down to the pelvis. And this patient is now a year and a half after the surgery, and she really had a terrific improvement of quality of life, and she's actually back to golfing and functioning at a very high level with a complete resolution of her L5 radicular symptoms, including weakness. I think with that, Christophe, it's now a bit after 5:50. What I'd like to do is open the webinar to any questions that might come from the audience. Please go ahead and type in any questions you might have. These were just the conclusions then that we were going to make, is that overall the HA Peak is a very favorable and novel interbody material that has been very favorable in most of our experiences. Christophe's got a very large experience using the device in the cervical spine. My experience has been with the lumbar interbody fusions as well as ALIFs. I think by comparison to alternative interbody materials, I think both the basic science and the preclinical evidence are really quite favorable, suggesting that the HA composite with PEAK really integrates into the adjacent vertebra very effectively. And again, our early clinical experience has really been very favorable, and I've not yet had to take any of my cases back for revision surgery for non-union.